Prince Charles Hospital in Merthyr Tydfil, South Wales is a leading specialist hospital in the area of diagnosis, treatment and follow-up of colorectal disease. The colorectal team are all dedicated to patient care and ensure that technology and innovation are at the forefront of the service they provide. Professor Haray and Mr. Masood, together with Mr. Joseph and all their staff, hope that this DVD will provide some answers and reassurance during this difficult time.
You've been given this DVD by one of the members of staff from the colorectal department because you've either been diagnosed with bowel cancer or are strongly suspected to have bowel cancer. This can be a very difficult time, not just for patients but their families as well. And it's because of that we have taken the trouble to design this DVD specifically to help you through the process of understanding the various tests and the treatments that you might have to undergo. The majority of colorectal cancer can be cured if it's caught early. And even for those patients who have advanced disease, there are still lots of treatment options available. This DVD will show you lots of different diagnostic tests as well as treatments. And I must emphasize that not every patient will necessarily have to go through each of these tests. I hope you find this DVD useful as you go through the process of the diagnosis and treatment for your condition.
When you arrive at the Prince Charles Hospital, your first visit may be to the Rapid Access Clinic, where the dedicated colorectal team will ensure you receive a range of tests to help diagnose your condition.
Many patients with bowel problems are referred to bowel surgery services. We assess these patients in our Rapid Access one-stop clinic. These patients have detailed examination of the abdomen and their back passage. Some of these patients may be referred for examination of lower part of the large bowel. We have facility to perform this examination on the same visit.
Following your referral from your GP, your visit to the Rapid Access Clinic and your clinical assessment, a series of tests will have been decided upon to diagnose your condition. You will then visit either the radiology or endoscopy department, or in some cases both. For the purpose of this DVD, the first section we shall concentrate on is endoscopy. Within endoscopy, there are two key areas: flexible sigmoidoscopy and colonoscopy.
I'm Jill, I'm the endoscopy unit manager. This is the department you will come into for your test.
My name is Anton Joseph, I'm one of the surgeons here. The test I normally do here is called flexible sigmoidoscopy or colonoscopy. It's a test mainly done for problems with the rectum or colon. A sigmoidoscopy is a camera that looks into the back passage. It goes to about 60 centimeters, mainly to look at the left side of the bowel. This is to investigate people who have bleeding from the back passage.
Before the sigmoidoscopy, the patient will be given a phosphate enema. It consists of a small flexible tube which is inserted into the rectum and the fluid squirted inside. After allowing the medication to work for a few minutes, the patient will be asked to go to the toilet and open their bowels. This will allow us clear views of the bowel when we insert the instrument.
This is the instrument which we use to examine the colon. As you can see, it's about 160 centimeters in length. It's flexible. You can turn the end longitudinally or side to side. This instrument is used both for flexible sigmoidoscope and colonoscopy. Flexible sigmoidoscopy goes about 60 centimeters from the back passage upwards, and the colonoscopy goes all the way to the end of the large bowel. Colonoscopy is mainly used for a few reasons. One is for diagnosis. One is for the surveillance. Actually, it can do procedures where we can take small growths out like polyps. You can actually cut it out. The patient who's going to come in next is going to have the surveillance. He has had surgery in the past for cancer, and we want to make sure that nothing has come back.
So Mr. Joseph has just started. As you can see on the screen, it's a very clear picture can be obtained of the inside of the bowel or the lining of the bowel. All the pink stuff that you see is the lining of the bowel, and obviously there is sometimes a bit of stool residue. Yeah, you'll feel a little bit windy, sir, but you're nearly finished now, and everything looks wonderful. Nothing to be concerned about there, okay?
Radiology comprises 4 tests: CT, MRI, barium enema and ultrasound.
Medical imaging plays a central role in the diagnosis and treatment of bowel cancer. It may be that the initial diagnosis is made on an X-ray, but imaging is invariably involved in the assessment and staging of bowel cancer.
Hi Matthew, I'm Richard and we're going to be carrying out your CT scan this afternoon. What we're going to do is see you've got a needle already in your arm. When you go through the hole, the machine's going to ask you to hold your breath a few times, and as the dye goes around the system, you might get a bit of a warm feeling. Nothing's going to touch you, nothing's going to hurt you, nothing unpleasant about the examination at all, okay? I'm going to go in the room now and you'll hear the voice asking you to hold your breath a few times. Within about 20 seconds, the whole examination is finished. The patient then kept for approximately 10 minutes outside just to make sure that they're okay before they can go home. We've all finished now. Feeling okay?
Yeah, fine, thanks.
Okay, gently over that way. I'm going to take you round to your cubicle and then you'll be able to dress and go.
Although CT is of some use in looking at the tumour mass itself, it's best, particularly for lower down in the rectum, to use a technique known as magnetic resonance imaging.
Hello, Mr. Thomas. My name's Tony Perkins. I'm one of the radiographers in the MRI scanner. We need you to keep still, and we're going to move you into the middle of quite a big machine that makes a lot of noise. And nothing will touch you, and you don't feel anything. But it's not an X-ray machine like the CT scanner. It has several very, very strong magnetic fields. So we do need to be sure that you don't have any metal on you that might cause a problem for us with the scan. You will need to go in feet first. Your head does go in a little way, but not very far. And it's going to take about half an hour, maybe a little bit less, but it depends on how we get on with the scanner itself.
A bare minimum may be the initial diagnostic test in patients who exhibit the classical symptoms of bowel cancer.
Right then, good morning sir. We're going to be doing a bare minimum on you today, so what the surgeon's requested, okay? What I'm going to be doing is popping the tip of this soft rubber tube into your bottom. It's got a hole in the tip. Run a bit of this barium fluid in, and the barium will show up on the X-ray screen on the X-rays that we take, alright? Tube will be a bit cold though sir, okay? It's got a bit of gel on the end which just helps it go in easily. I'm just going to inflate a small balloon now, so you might feel a bit of pressure, okay? That tube's in nice and secure now. So I'm going to start running the barium in a sec. Like I said, grip your bottom nice and tight, and the barium will stay in. After a couple of minutes then of it flowing all around your large bowel, we're draining it all back out anyway, okay?
Ultrasound is familiar to most people as the scan we use to look at the unborn babies of pregnant women. Ultrasound is done by an operator immediately beside the patient who guides the probe to look at specific organs rather than producing a cross-sectional map of the body as a whole. The signal is then fed into a powerful computer which is displayed as an image on the screen. For instance, if you wanted to look at liver, which we commonly do with bowel cancer, the technician would hold the probe over the liver and move it around in order to optimize the pictures that you can obtain. One of the best things about ultrasound is that there's a much more intimate interaction between the technician and the patient. Images in these four modalities are usually acquired by specialist radiographers and then viewed by radiologists, who then interpret the findings in the context of clinical and other information, which is then discussed at the multidisciplinary meeting.
Following the tests you have had in either endoscopy and/or radiology, a weekly meeting of all consultants, specialists, nurses and staff is held to decide upon the correct course of treatment for your condition. This is known as the MDM, or multidisciplinary meeting.
When we're dealing with patients with bowel cancer or suspected to have bowel cancer, it's often necessary to do a series of detailed tests and investigations. Of course, these include things like barium NMR, CT scans, MRI scans, and so forth. It's important then to sit down and look at these in detail to decide what's the best way to treat that individual patient, depending on the patient's own fitness levels, where the tumor is, what stage the tumor is at, how advanced it is or not. And then this kind of a decision is not taken lightly, and we have a big group of specialists from various departments, including pathology, radiology, doctors and specialists from the Velindra Cancer Center, our own specialist nurses from endoscopy and other specialists as required. And we meet on a weekly basis to sit down, and usually on a Friday morning before we go down to the clinic, to discuss the cases of patients who are likely to be coming in for surgery or treatment, and also those who have had their treatment last week, so we can decide if they need any further chemotherapy or further treatment. Majority of cases, even though the majority of bowel cancer cases can be dealt with surgery, there are some patients who will need some treatment in addition to that, or in some cases where surgery may not be the appropriate choice, and these decisions are taken in the MDM. And I'm just about to go and join the MDM. The rest of the colleagues should be gathering there now. And let's see what kind of cases we've got to discuss today. Good morning, everybody. Let's start off with I think the first patient is yours, Ash, is it?
Yes. You've seen him, Maria.
Yeah, I did. 2 weeks ago with fresh rectal bleeding. He's had no change in bowel habits and no weight loss and no other alarming symptoms.
Found a malignant looking lesion in the upper rectum rectosigmoid junction, so I biopsied it, and I organised some CT and barium to have a look at the rest of the colon.
Are the biopsies ready?
Yes, it's quite a good biopsy. It's a grade 2 infiltrating rectal adenocarcinoma.
So cancer is confirmed now. What about the X-ray test, Rodri, please?
He's had the full workup because it's a rectal tumour, so we've got MR images as well. Now this is the nice sagittal image, shows the tumour in its long form, and you can see it's got this apple core appearance which we see usually on the barium. That's looking promising for you boys to get out. We've also done a barium enema on this patient. As far as the rest of the bowel is concerned, I don't see any evidence of any other lesion in any part of the bowel here. So those are the pictures.
So there is no evidence of spread, and we have an operable tumour. So I will see this patient a bit later with Maria in our clinic, and we will counsel him for surgery.
Following the decisions made in the MDM, clinic is scheduled, usually the same day, to discuss the findings and course of treatment for each patient.
So would you like to come and see Doctor now?
Yes, I am. Yeah.
Hello, Alan. How are you?
All right, thank you.
Good. My name is Masood. I'm one of the consultant surgeon here. This is Maria Lewis, our senior colorectal nurse specialist, a bowel nurse specialist.
Yeah.
We have had a chance this morning to look at the result of your biopsy and X-ray in our multidisciplinary meeting.
Yeah.
The result of biopsy, Alan, showed a tumor in the lower part of the bowel. It's a cancerous growth. If I show you a diagram here, which would explain to you how the bowel looks like, okay? This is the bowel, which starts here on the right side. The appendix is usually here.
Yeah.
The bowel go around your tummy from right to left, and here is the bottom end, okay?
Yeah.
Your tumor is here. It's near the bottom end, but it is high enough so we can join the bowel together after removing this tumor without excessive difficulty.
Right, yeah. How long has it been there, and how large is it?
It is difficult to say, Alan, how long it has been there, but all tumors start with overgrowth of cells,
Yeah.
and these cells grow together and become a small polyp over a period of time. After another period of time, this polyp become malignant.
Right, yeah.
All right. How big? It is not that important. Some patient may have a big tumor which is well contained. Other patient may have a small tumor which has spread by the time of presentation. But in your case, it's an early cancer.
Yeah.
There's no evidence of spread outside the bowel. And we're planning to treat it as the majority of bowel cancer, which is by surgery. The aim of surgery is to cut the diseased bowel out and join the ends of the bowel together. After removing the diseased bowel by surgery, we send the diseased segment to the pathology for analysis. And if there is evidence of spread to the surrounding organs or to the lymph glands, you may need a course of chemotherapy.
You okay with everything that's been said so far?
Will I need a bag?
There is a possibility, as Mr Masood said, when we perform the surgery, the aim is to join the bowel back together. Okay,
Right, yeah.
but sometimes when they do join the bowel back together, they have to make sure that they're happy with that join, because your bowel will be active, obviously, straight after surgery. They will check that during the procedure, and if there's any doubt that they may need a period of rest for the bowel, they will then give you, on occasion, a temporary bag, which would be an ileostomy.
Right,
That would
yeah.
mean bringing part of the bowel out onto the surface of the tummy, and yes, you wearing a bag for a period of time. That would last for the time of the resting of the bowel until we recheck it with an X-ray procedure to see then whether we can reverse the stoma at that point. But there will be a period of time where you will have to manage the bag at home until we reassess it and bring you back in to reverse the stoma.
Okay. How long will the operation last, and how long will I have to stay in hospital after?
The operation itself will last about 2 to 3 hours, the surgery itself. But there is other time you have to count for, like anesthetic and recovery, etc. How long you'll stay in hospital, it's related to what type of surgery you would have. Traditionally, we used to do this sort of operation by an open method, which is a cut up and down the tummy. Nowadays, increasingly, we start using keyhole surgery, what we call laparoscopic surgery. If you heard about gallbladders operation,
Yeah.
it is similar to that sort. Basically, in a simple way, it's a number of small cuts in the abdomen, in the front of the tummy, and through these small cuts will introduce a camera inside your tummy, a number of long instruments. These long instruments will use to do majority of the operation. And then after that we will extend one of these small cuts a bit to allow us to remove an intact specimen of diseased bowel, which will be sent to the pathology lab for analysis. The main advantage of keyhole surgery and why we're doing more keyhole surgery now is the rapid recovery. And with rapid recovery, the complication of immobility like a chest infection or a clot in the leg would be less likely. If you have your operation by keyhole surgery, you can go home in 3 or 4 days if all well. We can't promise keyhole surgery obviously for every patient. Occasionally we may run in technical difficulty and then we have to resort to the old-fashioned surgery.
Okay.
And then you will stay in hospital about 7-8 days, if all well.
Yeah, okay. What sort of complications may I have?
There's always risk from the anesthetic with regard to the heart and the chest, and even a stroke.
Yeah.
But you will be looked after by an experienced anesthetist who would make sure that he will reduce the risk to a minimum. There is a risk from the surgery itself, like major bleeding, like clot in the leg, which we call it deep venous thrombosis, which can travel to the lung, infection, or something we call the anastomotic leak, which is where we join the bowel together. This area of join, or what we call anastomosis, can leak bowel content, and this is really a serious complication.
Right.
There is risk as well of damage of the surrounding structure and organs, and damage of the nerves which control bladder and sexual function, because they are close to the bowel. I'm taking you through some of the life-threatening complications for you to be aware that this is major surgery, and I appreciate very much that this is a worrying and anxious time for you. But I want to reassure you as well that you will be looked after by a specialized colorectal team. I'm a specialized bowel surgeon, and I'm working with a group of specialist doctors and specialist nurses who would look after you. We've been doing this operation for a few years, and we have excellent results here in Prince Charles Hospital.
Okay, okay. And when will I have my surgery now, is it?
Probably would be within a couple of weeks, 2 weeks. And I think I've mentioned most things to you by now. And if you excuse me now, I'll leave you with Maria. She will take you and discuss further details. Otherwise, I'll see you when you come in for surgery. Good luck, Alan.
Okay, thank you very much.
Okay,
Cheers.
I'll leave you with Maria now.
Thank you. Bye.
After the surgery, if we do it by open procedure, you may well have some drains and tubes in, one to rest the stomach, and obviously we need your bowel sounds to start to return before we allow you to start drinking and eating, but we certainly would expect you to be drinking by the following day.
Right.
If we do this by keyhole surgery, then the recovery rate is a lot quicker, and we would expect you to be drinking that evening, as early as that, and we would gradually then introduce diet to the menu.
Okay.
Do you feel that we've covered everything you need to ask us? Are there any questions?
No, that's quite fine.
Over?
That's everything I wanted to know.
Good. We obviously will be seeing you again for a further counselling session.
Yeah.
And you will have our contact numbers. If there are any queries or any problems through the process between now and the admission, by all means use the numbers and we'll try and alleviate any concerns or worries that you have.
Okay, thank you very much.
All right, and we'll be seeing you soon.
Okay, no problem.
Okay.
Depending on the treatment options, as discussed during the colorectal clinic, chemotherapy and/or radiotherapy may be required before any surgery is scheduled. Further information on preoperative chemotherapy and radiotherapy can be found in the extra section of this DVD. Any questions you may have regarding your hospital stay, surgery and recovery are covered by the ward staff. In the case of surgery, you are usually admitted to the ward the day before.
Hi, I'm Nigel. I'm a charge nurse here on Ward 1. We're a surgical ward and we will be catering for your needs during your stay here on surgery.
Hi, I'm Steve. I'm the ward manager of Ward 2, which is a surgical ward. I'll just show you around a second. This is where you're likely to come for your operation.
We'll assess your needs on admission. We have cubicles and also we have bays. And we will try and give you the care you need in an appropriate area. We have showering facilities, we have bathing facilities on the ward, and every individual will have a space where they can put their personal possessions during their stay. On admission, each individual will be assessed, and during this assessment by a qualified nurse, we will identify not just your needs during hospital stay, but we'll also go through what you require for surgery. We'll make sure you understand your surgery, but we look at what you actually need for discharge as well. During your stay, you will come across many of the multidisciplinary team. We'll have not just qualified nurses, but we have nursing assistant, domestic staff. We have a large multidisciplinary team with occupational therapists, physiotherapists, phlebotomists, just a small number of the people you may come across.
It's important to bring some clothes that you're going to be comfortable in post-operatively to walk around the ward and make your recovery much, much quicker.
We want every patient to make as quick as recovery as possible during their stay on surgery. So what we'll actually want is to get individuals up as soon as possible, often on the day of surgery, often the morning after surgery.
Right. Where next, Steve? Right. Okay. Is that Mrs. Fry? Post-op? Yeah, good. Good. Is she awake?
Yes, just about, I think.
Hello. Everything went well, my love. Everything went exactly as planned, no surprises, nothing nasty. And we've done exactly what we set out to do. Okay, I know you're feeling a bit drowsy and things now. I'll have a chat with you again later in the evening or tomorrow. Okay? Ob's okay post-op? Yeah? Good. Urine output and all that's okay there? Yeah? Excellent. She can have something to eat and drink today. No problems with that. So we'll give you something to eat later when you're a bit more awake. Maybe start off with a cup of tea or something and then have something to eat. But good. All right, my love?
Thank you.
Good. Excellent. We can get into the dripping things probably tomorrow.
Okay, great.
Good. Try and get some rest now. Right. Mr. Harrison in for tomorrow?
Yes, he's in the first building.
Right. Here's a chap.
He
We've
had
done
a laparoscopic colostomy, and
Yeah.
then he had preoperative
long course radio chemo.
He had a course of radio and chemo,
Yeah.
and now he's come in for his lap-AP resection.
Excellent. Let's go and say hello to him and see his bloods and things okay, girls?
That's normal, yeah. Been seen by the anaesthetist.
Brilliant.
Consented, yeah, ready to go.
Marked, stoma?
Yeah, he's marked. He marked this morning. The girls have been up.
Right. Let's go see him and see if he's got anything to ask before his operation. He should all be teed up for first thing tomorrow morning. We've got him on the list for first thing tomorrow morning. And we'll attempt him laparoscopy. There he is. Mr. Harrison.
Yes, sir. Please video.
Good afternoon again. Take a seat. How you been? We had a long chat Friday in the clinic
right.
last week. We talked about the operation and everything else. You've had the radiation treatment and the chemotherapy and everything, and you've come through that very well.
25 shots.
That's right. And time to try and see whether we can cut this tumor out now.
Right.
Yeah?
Yeah.
Any questions, anything that you're not clear about that we haven't talked about
No,
with the
I'm
operation?
sure I'm clear of everything you told me. I leave it to you.
We'll try and do this by keyhole surgery, but this is quite a major operation in terms of, it's not like the colostomy that we did first of all. That was a comparatively simple operation to do by keyhole surgery. This one, obviously, we need to be able to try and see if we can take the tumor out.
Right.
Take away the back, because the tumor is so close to the back passage, we'll have to take away the back passage as well.
Mm-hmm.
Leave you with a permanent colostomy. We'll see. If you can do it by keyhole surgery, we'll certainly attempt that. That'll give you a good chance for quicker recovery and better recovery. But either way, we'll get it sorted tomorrow morning.
Right, thanks very much.
Okay.
Yeah.
You've had a mark put on there for the colostomy? Yeah, you've had that done. Excellent. Good. If you don't have any other further questions, I'll see you first thing tomorrow morning then.
I'm quite happy with the way things have gone after now. So.
Excellent. And you've done very well through this, because it's been a long course of treatment and everything else.
Yeah, thanks very much.
Hopefully, let's get it sorted out tomorrow.
Right, thanks very much.
Good. Cheers. This is Mr. Harrison's CT now, right? And this is his post-radio chemotherapy CT? Yeah, we saw this last week, didn't we? And there's no evidence of metastatic disease or anything. And his bloods and things were okay.
Following a night of no food, the hospital staff take you to the operating theatre reception in preparation for your surgery.
Okay, good morning. I'm Cheryl Walden. I'm senior nurse for the department. This is the main reception area. This is where the start of the patient's perioperative journey is. So first thing in the morning, or whatever time of day we book in the patient will come into this area. Behind the desk we have a receptionist. This morning is Sister Pooh. Patient comes in, the first thing we do is greet the patient. Obviously the patient's coming from the ward, the patient's very nervous, he's coming down for surgery, he wants a nice warm welcoming face from a nurse. This area is very important to collect information about the patient. The first thing is we want to make sure we've got the right patient for the right surgery so we can give the patient the right care. Patients are made warm and safe and comfortable in here as possible. This is Theatre 1, the colorectal theatre. This is the anaesthetic room. This is where the anaesthetist and the ODP would greet the patient before they go under anaesthesia. Doctors read your breath, okay? This is perfect. Look after you, okay?
Hello, sir. Morning.
So then before we start, we're going to go through the same checks now that we went through in that room there. What's your address, Fed?
6 West there. Okay, now, this is
For some of you who have never been to theatres before, we are the anaesthetic team. We look after you during the operation, and we also look after you after the operation.
A number of patients undergoing colorectal surgery or major surgery, they've got some pre-existing medical conditions. They may need ITU admission and post-operative intensive care monitoring.
We take you into the anaesthetic room. You will be in the company of an anaesthetic doctor and one of the operating department practitioners, and we keep you as relaxed as we can. We connect you up to the monitors, put in special lines before you go off to sleep, and then we explain every step of the way what we're going to do. The most common anxieties that I've seen during my career, patients ask are, am I going to be safe during the anesthetic or during the procedure? The most important monitor in the theatre is the anesthetist and his team. We'll keep an eye on you, we'll not move from the theatre throughout the operation, and we'll be looking after you. That's number one. And this is the commonest. People keep asking, will I be awake? Will I wake up during the operation? The present day sophisticated monitors keep us informed well in advance what's happening with your body functions. Our aims are very simple and very clear. We have to keep you safe during the operation. We have to keep you pain-free after the operation.
Well, the two types of pain relief for this sort of operation would be something called a PCA or an epidural. An epidural is a very fine tube, which is a flexible tube which is passed through a needle into the back between the bones of the spine.
After the operation, you will get a pain relief called PCA, patient control analgesia. The pain relief is morphine. It is quite very effective.
Rest assured again that we will only send you back to the ward if we feel that you're fit enough to go back to the ward. Otherwise, you're going to be in the high dependency where you'll be monitored for 24 hours. It is to keep you safe.
What we're about to do today is quite a major surgical procedure, cutting out rectal cancer in a patient who's had preoperative radiotherapy and chemotherapy. To do this kind of major procedure, whether you do it by keyhole surgery, as we're going to attempt in this case, or whether you do it by open surgery, you need a lot of specialist support from various members of staff. And here, for example, to assist me and support me to this operation today, I've got the anesthetist, senior consultant anesthetist there, Dr. Aziz. He's assisted by Patrick and Anita, one of his junior doctors. And we've got several other members of staff on the patient now to assist me with the operation itself. Two of our registrars, Mr. Shah and Mr. Kumar. Nairion is one of our theatre assistants. Laura Dixon is one of our senior staff nurses who does these kind of cases regularly. And then Jane Corino is another staff nurse who is not scrubbed up in the case, but you need to have several members of staff who are not necessarily scrubbed up to actually operate, to support the team that are actually doing the operation. Jane Corino is there. Karen is one of my other junior doctors who's not taking part in this particular case. Sister Judith, but is the senior theatre sister for this theatre. And at the back there is another theatre assistant there, Craig. So as you can see, it takes a lot of people to be able to deliver complex care, and all of these people have their own specific jobs for which they have trained for many years, and they are specialists in their own right. So very often the patient only sees the surgeon or the outpatient nurses or the junior doctors on the wards. But I hope this shows that you need to have a lot of complex kit equipment-wise, as well as complex expertise to be able to provide advanced surgery.
We have our recovery area with a dedicated recovery staff, and as you can see, we have bays in here that when the patient comes out of theatre, they come into the recovery room. Once the patient is made comfortable, pain-free as possible, the ward nurse is rung, and then the sister or the qualified nurses in recovery hand over to the ward nurse, and then the patient goes back to the ward. That's the end then of their perioperative journey.
After surgery, the ward staff provide round-the-clock care and ensure that you mobilise as soon as possible.
Once you've had your surgery, it's an anxious time, not just for the patient, but also for patient's relatives. Visiting hours are restricted between 3 till 4 and 6:30 till 8. And this is to allow the patient to have an adequate recovery period.
We welcome visitors and we welcome inquiries from relatives. Both myself and Nigel are normally around to answer any queries, along with the staff nurses who have been caring for you during your admission.
Not everybody will have the same level of recovery, but what we'll do is we'll tailor your care to meet your needs.
The doctors will do daily rounds where your care and treatment will be adjusted.
There will also be a nurse present throughout the time of these rounds so that they can also explain to you any problems you have.
It's been less than 24 hours since Professor Hooray operated on Mr Harrison, and Mr Masood, as part of the close-knit team, has come to check on his progress.
Good, good. We did. Good. I had 2 sandwiches last night. I got breakfast this morning.
Excellent.
2 tours, cornflakes and milk.
And you had your operation yesterday?
Yesterday morning.
Excellent, excellent.
His obs are fine, numbers are okay, he's got no temperature, pulse and everything is normal.
Okay. Yeah, looks pink and healthy.
And he's had a stroll in the corridor as well, walking, and he's ambulating. Excellent, well done, sir.
I don't think that you'll take a long time before you go home. Okay?
All right. Thank you
All right.
Thank you very much.
Okay. Excellent.
Thank you, sir.
Well done, sir.
Thank you.
At the weekly MDM, your surgery and post-operative recovery is discussed, and any follow-up treatment options agreed.
The next chap on the list is a gentleman I operated on last week. We discussed him a couple of weeks ago pre-operatively. He had a tumour in his right transverse colon. We've done an extended right hemicolectomy on him. He recovered very well, he's gone home. We need to see the post-op histology.
Did you do that laparoscopy?
Yeah. It is suitable for a laparoscopic case, so we did it keyhole surgery, straightforward. He went home in 3-4 days post-op. He is recovering well at home. Histology, please.
This is a composite, as you can see. I've actually brought down photographs of the growth for you because there are a number of issues. There is evidence of lymphatic involvement, and also he has lymph nodes positive, as demonstrated by the bottom image on the right-hand side. So putting it all together, he's a Duke's C1, the apical nodes were free. He is TMN stage T3N1.
Is he fit for chemotherapy? Or?
Yes, I've seen him at home recently and he's relatively fit and well.
He's got a high risk node positive cancer, and he's got lymphovascular invasion. So I think we should be giving him adjuvant chemotherapy to reduce the risk of cancer recurrence. So whenever he is reasonably fit, if you send a referral across, it's probably no point seeing him
He's
now.
fine because we did his operation laparoscopically. His recovery is that much quicker. He's already gone home 3-4 days after the operation, so you can start teeing him up as soon as you want.
Okay, I'll arrange to see him in the next week.
Are you going to be giving him anything particularly complicated, or is it something we can use in our own oncology department here? Because
we should
majority
be,
of our cases we can do
yeah,
here.
whatever chemotherapy we give, we should be able to give it here, isn't it?
What regime are you considering?
Well, if he's quite fit, we will consider him for oxaliplatin 5FU regimen.
And we can manage that here anyway, so we don't have to have him going back and forth.
No.
Okay, so we'll get him booked into Dr. Mukherjee's clinic then. Okay, cheers.
Hello, Mr. McDonald. How are you feeling after your surgery?
Very good, thank you.
Great.
Yes.
I'll just pop you in to see Professor Array. Okay, would you like to go in?
Thank you.
Oh, hello.
Take a seat over there.
How are you, Mr. Array?
Hello, good to see you. Good to see you. Come on then. You're looking very well.
Yes, I'm feeling very well, thank you.
It's now what week, 10 days now since
your
operation?
Yes.
Right, as we promised you, we've got some results for you. We took away a piece of bowel last week, and we've had it analysed. Pathologists have looked at it. We've looked at it this morning when we have our weekly discussion. And the tumour itself is out, okay? The bad bit is all gone. But some of the lymph glands around the tumour have shown some malignant cells. The cancer is there and the lymph glands around. Now this doesn't mean anything other than the fact that usually in these situations it is better to give you some additional treatment in the form of some chemotherapy. All right?
Yes.
Before you start asking me what kind of chemotherapy and the details and all that, this will all be explained to you in detail from our specialists from Velindra who come up here to do the clinic with us. In fact, they're doing a parallel clinic next door.
Okay, right, thank you.
The majority of locations, we've got the facilities. We've got the facilities sorted a couple of years ago, so we can provide the treatment at this hospital itself without having to go back and forth to Velindra. But that's not always the case, but in the majority of cases.
Okay, right. Yes, right. Thank you.
You're looking marvellously well.
Yes, feeling well as well.
Let me go and see if Dr. Mukherjee or the specialist nurse with him is available. And if possible, they can see you today itself.
Okay,
Talk
great,
to you
thank you.
about, what kind of treatment, etc.
In some cases, post-surgery chemotherapy is required. Prince Charles has an outreach chemotherapy unit with the facilities provided by Velindre Cancer Centre.
Hi, I'm Dr. Mukherjee, and this is Helen, who's our oncology generalist nurse. Please take a seat, sir. How are you getting on?
Oh, very good, thank you.
How did the operation go?
Professor Reid told me that the bowel cancer has been successfully removed.
Yes, that's right.
Along with several lymph glands. He believes that giving me chemotherapy will be like the belt and braces of the treatment to try and reduce the possibility of the cancer returning again at a later date.
When we looked at the tumour, because we looked at your tumour in the multidisciplinary meeting, we just think, is it possible that the cancer may have just drifted out a bit? And it may well be possible that there are a few then circulating within your body, and we really need to sterilise them. It obviously isn't too bad because we've had a CT scan and everything, and none of them have shown any traces of cancer.
How long will this treatment take, and how often will I have the chemotherapy then, doctor?
Right. I mean, you're quite a fit and well gentleman, I hear from Professor Hooray. So I think, we will throw at you whatever we've got. It involves a drip, which is called the oxaliplatin, which is given over 2 or 3 hours. And then you are connected to another chemotherapy called 5FU through a long line. And through that long line, we give you the chemotherapy for another 48 hours. And then you come back again 2 weeks later to have your next treatment. Right. So you kind of have about 12 treatments over a 24-week period. So that's about 6 months.
6 months.
The first thing you would need is what is called a PICC line, which is a long line. And the way it is done is all done at Velindre Hospital. There will be a nurse who will do it under local anaesthetic. And so you have the line fitted in first, and then you actually start the treatment.
Are there any side effects with this chemotherapy?
Really, the only way to know is to give you the treatment, and then we will assess you after each chemotherapy to see how you're doing. And obviously Helen will be doing a lot of the assessments as well. And then we can either modify the dose of your chemotherapy or reduce the dose of your chemotherapy as necessary.
Will there be sickness, and am I likely to lose my hair?
You're unlikely to lose your hair through the treatment. Sickness may be a problem, but in these days in time, I mean, there are very good anti-sickness medications. And it is highly possible that you're not going to take all that in because it's a lot of information. That's why we give you the printed leaflet, and then I'll see you back again after you had a good read of the leaflet, had a chat with your family, and we will take it from there.
Okay, right.
All right.
Yes, thank you.
Take care, Mr. MacDonald. I'll leave you with Helen to have a little chat now.
Okay.
Okay. Bye now.
Thank you.
Bye now.
Bye.
Mr. MacDonald, the one thing we haven't covered today is that chemotherapy can actually affect your immune system, and it can affect your blood counts. Okay?
Right. Yes.
And each time, you become to clinic every 2 weeks before you start your next treatment, and we need to do your blood counts, see how you're coping with the treatment, like Dr. Mukherjee outlined, but also that your blood counts are okay. We will, on the day of the chemotherapy, give you medication, as in anti-sickness, anti-diarrheals, mouthwashes. So you've got them just in case, okay? Because your mouth is going to be a bit more at risk of becoming sore as well.
All right.
And a huge part of my role is to ensure that you've got the support, advice and guidance throughout your treatment, okay? And not just in clinics. You will be seeing me regularly throughout them.
Okay, right.
So you know.
That's right.
So I'll be 10 minutes and I'll be back with your appointment times and start
Okay, right.
dates.
Thank you,
okay?
Helen. Yes.
No problem.
Thank you.
I'm Helen O'Neill. I work as oncology nurse specialist within Prince Charles and Velindre. This is the area where all the patients receiving chemotherapy come have their treatment. I mean, one of the greatest things about this centre is that it obviously is local and doesn't require, travelling that distance for poorly patients as well. And also they're not relying on friends and families taking time off work. So they can just come here for a short treatment particularly, and it's on their doorstep. They get a continuity of staff as well, so they get used to the staff, and the family are allowed in, and it is a relaxed environment. The patients all on chemotherapy I will see regularly throughout treatment, and I'm available for telephone advice and support throughout treatment as well. And I work very, very closely with the Velindre chemotherapy outreach staff who obviously participate in the running of this clinic.
Follow-up is scheduled for each patient depending on their specific requirements.
Following surgery, each patient will have a 6-week follow-up in the surgical outpatients department to make sure that they've fully recovered from the surgery. If they then need to go on to have adjuvant chemotherapy, they would have had an appointment with our oncologist and a regime would have been started for that oncology period. They will stay with the oncologist until treatment is finished, and then they're handed back to the nurse-led cancer follow-up clinic at Prince Charles Hospital. Hello, Mr MacDonald. How are you feeling? That's led on a 6-monthly basis for each individual patient, and the patient is seen by myself or on occasion by Debbie or Sue, our other colorectal nurses. The plan thereon will be that you will be seen by myself on a 6-monthly basis for 5 years. During that 5-year period, you will have CT scans on a yearly basis, and you will have another camera 3 years from the date of your surgery, okay? And that will be to recheck all of that bowel again. That camera will then be repeated again 3 years on from that. And we will continue your follow-up after 5 years on a yearly basis until, you know, up to the point of your second camera, which will then we can sit down and discuss more of an open contract between you and myself to come back to the clinic if you have any problems.
Okay.
Okay?
Yes, fine.
Now we'll give you a leaflet on all of that
Okay,
to just reinforce everything, because it's a lot to take in one
Yeah,
session.
yes, it is, yes.
Okay?
Okay, right.
All right.
Thank you.
Obviously this is audited on a continual basis, and any new research or any other advice or statistics that improve the service will be taken on board, and things can alter through the course of the follow-up period.
As a group of professionals dealing with this condition on a regular basis, we are all very aware that this can be a very worrying and difficult time for patients and their families. This film has been made possible with the help of many of the staff here at Prince Charles Hospital. I hope that it gives you an insight into what to expect during the process of having the diagnosis and treatment for bowel cancer. If you're not clear about anything at any stage, please feel free to ask one of the colorectal team.